Okay, welcome everybody to this call on adding value to QI projects and learning from ERA and the NHS with Dr. Tom Rose. My name is Maria. I'm a Q community convener and just gently hosting you guys today. We have quite a simple schedule for today. Tom is going to share his research and his roadmap and chat for about 20 odd minutes, and then we'll have some time for questions. So during that time of Tom presenting, please put your questions in the chat and we'll get back to them when it's time for Q&A. And then after the Q&A, Tom will do a bit more presenting, and then I think at the end, there'll be some time for Q&A as well again. So yeah, I'm gonna hand it over to Tom. And yeah, here you go, Tom.
Hello, everyone. Thank you very much for joining us. I'm just going to share my screen so that you can see my slides. Okay. I'll get back to the beginning. Now, you can all get access to these slides. The URL is at the top there, but I will provide it at the end of the lecture as well, so that I've really put a lot more information on the set of slides than I'll have time to talk about, but you can then have a look at it in your own time and try and tie some of the things together that I've been talking about, because it's quite a big change that I'm talking about, and a lot of effort that would be required to achieve that change. I'll just whip through a bit about me. I'm a retired chartered engineer, a chartered quality professional, and fellow of the Institute of Continuous Improvement in Public Service. I've worked in manufacturing, including the car industry, where a lot of the quality management principles evolved over the years. I've been involved with quality management, and particularly the standards that are used to sort of standardize the way that we approach quality management since the 1980s. So in those days, ISO 9000, as we call it now, was called BS 5750. It was a British standard and then became an international standard. I've also been involved in the standard for software quality, software writing quality, and that's called Ticket. It's ISO 9001 again. I've taught business improvement techniques, the MVQ of business improvement techniques. I spent quite a lot of time at university, and at one stage I did a PhD in process management. So hopefully I've got a lot of experience in process management, and process management applies quite nicely to patient safety, human factors, and quality management systems. There's a bit about my main characteristics. I'm quite dyslexic. I've been an apprentice, a soldier, an outward-bound instructor, an engineer. I've worked in industry, in education, research. I'm a paddler. I'm a runner. And you can, if you're interested, there's a link there, and you can see some of my kids and my grandchildren. I'm a mountaineer. I've done a lot of work with the Duke of Edinburgh's award, and I work solely as a volunteer nowadays. What I'm going to talk about today really is a roadmap that I've created for change in the way that the NHS manages its day-to-day activities and error and patient safety. And in order to implement that roadmap, I've looked at what sort of framework that you might need. So I'm covering quite a lot of detail today. Starting premise. I'll get going now. Starting premise. I've put together a couple of formulas, and in my view, both of these formula have to be met if the NHS wants to start managing quality and managing patient safety. They're really preconditions. And the first one, WAD equals WAI, that's work as done equals work as imagined. There's quite a lot of talk about work as imagined and work as done, and there's quite a long gap between the two. Well, they have got to be equal for quality to be managed and patients to be safe. And the second formula is that QI has got to equal CI, and that's quality improvement has got to equal continuous improvement. And there's a big difference between the two, but the tools and most of the processes are the same. So QI needs to be there. It just needs to be focused on CI instead of QI. I'll go into what I mean by this in a bit more detail, but try and remember those formula, because I think they're really important. Without those being met, I think that the job of managing quality and managing patient safety will be very, very difficult in the NHS. And we're going to talk quite a bit on what the Virginia Mason Institute have been doing with the NHS and what they do themselves. And they certainly have applied these two formula, although they probably don't state it in so much. Okay. First of all, a little bit about organizational knowledge, because that's really important. What Virginia Mason want to do is innovate right the way across their healthcare system. And you can't innovate unless you've got quite a lot of knowledge about your organization, not only your aims and objectives, but also what you do on a day-to-day basis. And there's a little passage here about what organizational knowledge is. And the organization shall determine the knowledge necessary for the operation of its processes to achieve conformity of products and services. Now that's the most important statement there. I won't go into any more of the spiel there because you can read it yourselves. But an organization shall determine the knowledge necessary for the operation of its processes and to achieve conformity of products and services. That's really, really important. It mentions processes, or I mention processes all the time. So what is a process? Well, the new CQC framework talks about processes, and they've put a little bit of a definition here. Processes are any series of steps, arrangements, or activities that are carried out to enable a provider or organization to deliver its objectives. Well, that's not really true. It's a series of steps and arrangements and activities that are carried out to enable the process to change its inputs into its outputs. Not the input into the organization and the output out of the organization, but on a process by process basis. And then they go on to talk about not really processes that you do on a day-to-day basis to do your work. They talk about processes that enable you to meet the requirements of the CQC framework. So I don't agree with that definition all that much, but we'll come on to that. What about processes in the NHS then? Have you got complex processes or just a mess? And what I'm talking about is, how do you sort of document your processes? Because if you're not documenting them, you haven't really got a process. You've just got a bit of a mess. So let's see how the NHS documents its processes. This is a little blog by Claire Cox, who's on the patient safety, a patient safety lead at King's College Hospital, and she was trying to demonstrate to her team the difference between work as imagined and work as done. So there was a bit of disagreement within the team about how work was done. So they thought they'd have a look at work as imagined. So they collected all of the standards and guidance and stuff associated with that particular process or the service within that, the process within a service. And they found 150 different standards or documents relating to that service. Some of them contradict each other, and some of them were absolutely impossible to comply with. So that to me is an unmanageable situation. You can't expect a sort of a fairly simple process to have 150 different sets of instructions of telling you how to do it. If you're going to have work as done equaling work as imagined, you've just got to have one set of documentation describing the activities in that process. So there's an example of why I think that some of the processes in organizations are just a bit of a mess, because they're very ill-defined. If you've got 150 different instruction sheets of the same instructing you to do the same thing, then the whole thing must be ill-defined. So what I've done is created a little bit of a roadmap to see how that can be changed within the NHS. So here's my roadmap, and it took a long time in design, this roadmap. So there are 3 stages in the roadmap, and what I'm suggesting is that first of all, the NHS needs to develop a process management system. That's where the formula work as done equals work as imagined comes into being. And there's quite a lot of documentation within the NHS that identifies your processes. And the one thing that's missing from this little list is the clinical pathways. And I'm hoping that the get it right first time clinical pathways are starting to influence work within the NHS. So first of all, a process management system needs to be created. And I'm going to talk about how you start to do that a little bit shortly. And that will lead on to being able to design a quality management system for the NHS. Basically, following the requirements of ISO 9001, but not getting registered to ISO 9001 because some parts of it are not 100% relevant, and I think the NHS needs to pick out the bits that it needs. There is a healthcare version of ISO 9001 that not many people will have seen, but it is a very good standard as well. But again, that's quite a demanding task to meet that standard, and I wouldn't suggest that the NHS attempt to do that certainly not in the short term. But there are some organisations that can help with the implementation of a quality management system in the NHS, and 2 of those would be the Chartered Quality Institute and the British Standards Institute. They both offer training. And then that quality management system could be developed into a safety management system. And the safety management system would really be part of the quality management system. You don't really have to have 2 separate management systems or 3 management systems, as I've shown here. That they'll all sort of evolve into a single management system. And this isn't a people management system, it's a work management system. It's what you do at work, not how your staff are organized or managed. It's a work management system, not a people management system. So the HR type management systems and the hierarchical management systems within any organization still have to be present. These are just sort of additional management systems that manage your work and of course the quality of your work and how you address error within your work, and most importantly how you innovate, how you can really take advantage of modern ideas, and how you can develop your staff to be able to implement those ideas into their day-to-day work. So that's quite a large task going through those 3 steps, and I'm not suggesting at all that it could be done in a short time. It would take years to get to the little bit of writing there in red, a just culture. I've used the term just culture because it's something that appears quite a lot in a lot of the literature that I read about the NHS, and within this, I mentioned earlier, within this process management system, you've got clinical pathway management as well. I've just done a little bit of a Gantt chart here showing that I'm not at all suggesting that this is going to be done in a short time. And these things, once you've got the first one going, you can move on to the second one before you finish the first one, and same with the third. So that's what I'm suggesting. It is a roadmap for changing the NHS now, so that we've got a situation where WAD equals WAI, and also QI equals CI. QI, as you will all know, is quality improvement, which is evolved within the NHS to improve quality. CI is different. It's got the same aim. It improves quality, but it's based on process, not output. I'll just give you another slide right at the end here of how Toyota Kata is Toyota is where the Virginia Mason Institute developed its production system from. Virginia Mason call the delivery of their services a production system. I know that the NHS is very much against coining language from industry, but the Virginia Mason have taken it on board straight away and said, we are now operating a production system, not delivering a whole series of services. So Toyota say that their CI effort is all focused around the nature of people's action at the process. That word process is coming up again. It's really important that people understand process. Whereas a lot of UK industry and the NHS management focus, including QI focus, is focused on process outcomes and consequences. If any of you don't agree with that, then you can ask some questions in the chat. But this is really important when it comes to the difference between QI and CI, because this is where CI, continuous improvement, operates, and this is where predominantly QI operates. Now, CI and QI use all the same tools, all the same management tools, improvement tools. They're exactly the same. It's just that the focus is at the process rather than at the outcome and consequence. That's a really important distinction to make between the two. Okay, I think now, after having gone through that fairly quickly, we can address some questions if there are any.
I haven't seen any in the chat. Yes, there's one from Rashid here. Would you like to just ask it yourself, Rashid, and come off mute?
Yeah, hi. Thank you very much. I'm new to this kind of understanding, and it's quite interesting. And what I wanted to know is this kind of process map for changing the culture. Is there a healthcare-based evidence or a good example where this framework, because it seems like the work has been going on for a long time, at least since 2015 as per your slide. So is there a good example where this has worked prospectively rather than as a theoretical framework? For example, if I want to prospectively do it for a study, then can I quote evidence for this kind of framework? Thank you.
you can't quote evidence of it from within healthcare other than Virginia Mason Institute. There are some trusts that have gone a long way in this, developing what is called standard work. Some of the reports that the Virginia Mason Institute have produced on their work with the NHS demonstrate some of that, and there are one or two trusts that are trying to move forward on this, and they're usually members of the Q community, and there's a few special interest groups within the Q community that are addressing it. But there's thousands of examples from industry, and I'm going to come on to a couple. In fact, I'll show you now. It doesn't matter if I move about a little bit, but the Virginia Mason Institute have produced three books, and the third one is on leadership. But the first two are more on standard work, and the first one is called Transforming Healthcare, and it was published in 2011. And they talk a lot about standard work and say that for many doctors and nurses, the most difficult part of the change involved the focus on standard work. A lot of poor quality comes about through variation and lack of standardization. And they also say in that book, without standardization, you have no ability to measure what you're doing. Without standards, there can be no improvement. So Virginia Mason have got a lot of examples. And the standardization is, sorry, click the wrong one. The standardization comes around here. This is where you standardize all your work when you create a process management system, because the process management system standardizes and implements all of your processes. One important thing here is it's a bottom-up change. Processes are documented by frontline staff as work as done and not as work as imagined. So the starting point of standardization is documenting work as done. And then through a continuous improvement process, you get closer and closer to meeting some of the standards that are suggesting how that work should be done better. But you, as I've already said, you can't comply with all of them. So it's a question of working out what it is that you want to apply. Now, you asked if there were many examples. Well, as I said, that the best examples come from organizations like Virginia Mason or industry itself. The best one in industry is Toyota. The Toyota management system is probably the best design of a system that manages quality and safety. And I'm not saying that Toyota invented it, because British industry has been following that same system for many years. It's just that Toyota has documented it all and written a few books on it. I hope that answers your question. I think I rattled on a little bit.
Yeah, it does. I just wanted another clarification. Sorry if I'm taking the time. So slightly away from the industry like Toyota, the complexity within healthcare, to my understanding, seems slightly different. Do you have anything to suggest that it will still be valid in a complex system where standardization is quite challenging, I feel, compared to like manufacturing?
Yeah, it depends on how you do your standardization. Now, there's two elements of standardization in healthcare. One is the patient, the clinical pathway, and one is standardizing the clinical pathway, which Get It Right First Time has been doing, and NICE have done lots of work on doing that. And the second one is standardizing the processes within that pathway. Now, standardization in the NHS has always got to take into consideration the patient, and no two patients are the same. So the standardization has got to have a degree of flexibility within it, because because what's the point of going through all of the training that the clinicians in the NHS do just to be told how to do their job? The standardization only standardizes sort of parts of the process, not so much the hands-on clinical activities. So because not many people have attempted this in healthcare, it's difficult to talk about what the end product would look like. It's a question really of, right, we've got to go ahead and do this. Someone's got to take the step like Virginia Mason has done and say, let's get it standardized. Let's start doing it. Let's see what it looks like. Now, Virginia Mason will help with this. They've been contracted to the NHS for about 14 years, I think.
Great, thank you.
Okay.
Okay, I think Nick is the next one.
Yeah, thanks, Maria. Hi, Tom. Nick Holden. So, as you know, I worked with Virginia Mason for several years, so I recognise a lot of what you said. That relation between CI and QI. I think if I can point Rashid in the direction of Surrey and Sussex or University Hospital of Sussex on the south coast, probably two healthcare organisations in this country, in the NHS, that have developed started work well and have got their model, their improvement model well established, which mirrors similar to what Virginia Mason have done. They've learned a lot from Virginia Mason over the past. But my question, Tom, is more about, there's a prevalence across the NHS that I see at the moment, which is, as you said, more reliant on QI, but beyond that, more sort of QI projects, which is singular, defined, very limited in terms of its scope, which is, for me, kind of the opposite of what a quality management system is looking to develop. It's very much like pet projects, often things that people are interested in, but it does feel to me like there's a that's the predominant direction, and where the terminology sits in the Q, in just using the word QI is often seen as it's separate to the day job. It's a bolt-on. It's an add-on that we can do if we have time. What's your thoughts and reflections on that? Do you disagree?
No, I agree. QI is too involved. To do a QI project, you've got to have all sorts of standard written documentation and report writing and all sorts of things. And really, the improvement is better off just being a small step where you don't really need any documentation or reports or all of the paraphernalia that goes with a QI project. It's a fairly simple thing that the work team just get together in the morning and say, look, we've been talking about a slight improvement. Let's do some PDCA tests around this change and then make the change. Not have loads of write-ups about it. You can only do that though when you're working from a baseline, working from a standard. If you're working from a starting point where everybody's doing everything differently anyway, then you see a lot of QI projects, they start off by saying, well, let's work out how people do this work. We'll do some process mapping and find out how they do it. Well, that's really a waste of time. People are doing that work every day. Why do you need to have a process map to work out how they're doing it? It should already be in existence. So then your QI projects, or CI as I'd prefer to call them, would be much smaller and much easier managed. You don't need to have all these write-ups. Let NICE and universities make all these big changes. Just do the small changes that make your working day better and safer. Does that answer your question?
Yeah, it was. I mean, I agree in terms of the leaning more towards just continuous quality improvement rather than quality.
Yeah.
I suppose the point I was making is that it is the continuous element of it, which is the difference between a start and finish point of a project, of a QI project, which may be sort of limited in its scope. And I just want to sort of draw out that point of it is continuous rather than the project feel of it, that is there's a start point and an end point, and that's the sort of mindset is, as you described, is let's just do some stuff and see where it goes.
Yeah, let's get it going. But Toyota don't really have standard work because they're always improving. They'll say, no, we don't have standard work. We just have work that's continually improving. And it's improving in these very, very small steps, not a big step. And if you're, you know, quality is really in the hands of the people doing the day-to-day work. And if it's not, if the changes aren't made to the work that they do, then you're not going to change the quality. That's my view, and the view of Virginia Mason and Toyota. And I've read the work that you've done down in Surrey and Sussex in one of the Virginia Mason reports, where you actually have in your triangle you have actually got standard work written in.
Yeah, it's not my place. It's I'm just aware of it. Thanks, Tom. That's been great.
Okay, cheers.
Okay, are you okay to take these 2 questions, Tom, and then maybe you can get back to people who've asked questions in the chat after the call. So Lindsay, what's your question?
Hi, Tom. Really interesting sort of concepts here. In Herefordshire, we are moving away from the QI kind of pet project world into improvement being everybody's business and supporting teams and individuals to make sure that improvement is everybody's business. We're struggling with measuring our value. So how can have we got any thoughts, or can you point me anywhere in any direction around, we're looking at the value that we can add to support people so that it becomes their improvement and we are not project managers anymore. And we're looking at all the different realms of value that we can add. But obviously, I think, well, it feels like that there isn't an awful lot out there for us to kind of evidence or any ideas around that. So any thoughts, much welcomed.
Did you say you're in Hereford?
Yes.
Yeah. Well, I'm in Malvern, so
excellent. We'll have a coffee.
I'll come across and talk to you sometime if you want.
Super. That'd be amazing.
You can get my email at the end of it, so you can get in touch with me.
Excellent. There we go. That answers my question.
all my work is as a volunteer as well. Anyway, organizational knowledge. The best way that you can learn that you're adding value is understand exactly what's going on, and that's not just the people doing the work. It's everybody in the organization. I always used to say when I was working in industry that a lot of the people that have got a really good view of what goes on are the cleaners, because they can look around whilst they're working. You know, when they're pushing the broom in the factory, they can notice what goes on. So I used to get information from the cleaners and say, well, what do you think about this? You know, organizational knowledge is so important, and most of that organizational knowledge is tied up in your processes. That's why you've got to really understand your processes, and you'll only do that, first of all, understanding what a process is, and then secondly, understanding how that process operates. I'm going to come on in a minute to more detail about processes. So anyway, I hope to have an email from you soon, and we'll jack up a meeting.
Awesome. Hey, dear, would you like to ask your question?
Yeah, thank you. Tom, thank you so much for the presentation today. So I come from a mental health background, which has in its way its own challenges when it comes to standardizing things and evidence-based practice. I just wanted to ask a question, perhaps more for clarity. Typically, we would have policies, and then under the policies, we have our standard operating procedures at a kind of service level. I'm just curious, when you're talking here about your process mapping and that process management system, and you're talking about it being bottom up, how granular are we talking here in terms of the definition of the processes and the tasks? Because you'll have some challenges in terms of variations between teams, resources, external factors that could be in play that you need to respond to within NHS. So it's not like I imagine in manufacturing where you would have an expected output, you're always going to be producing a car, or you have some sort of stability. We're having to deal with a lot of dynamic factors because of external pressures that we have within NHS. So I'm just curious, how granular do you envisage this process mapping and kind of that setting of standards to be?
Yeah, I'm going to go on to that in a minute when I talk about standard work in more detail. But I'm not sure that I agree with your definition of complexity. When I was working in industry, we built machines that a whole series of machines that went into in my last work anyway into can making. And I don't know whether you have ever seen a machine making a can, but they make them by the thousand every second. You can't actually see that individual can they're moving so fast. And the whole of that factory, which has probably got 500 or 600 different machines, all individually computer controlled, are controlled by a central computer. And the people that work in that factory have got to understand exactly what's going on from the front end to the back end, because the cans don't stop. It's the same in the car industry. When I was working in the car industry, you get 4 wheels at one end and you get a whole car at the other, and the thing doesn't stop all the way through. And you've got robots, you've got supply chains, and you've got nuts and bolts, screws, all sorts of things all the way along that supply chain. And it's very, very, very complex, very complex. And I know that what makes the NHS even more, possibly more complex, is the nature of the patient, because I said earlier, the patient is an individual and has got those individual needs, and there's a lot of compassion required as well, which isn't really the same as in industry, although quite a lot of people that work in industry are quite passionate about the standards of the products that they produce. So you've really got to start by saying, okay, let's do it. And how do we do it? Because no one's doing it apart from 1 or 2 people, like we heard from Mike earlier about Surrey and Sussex. It might be worth asking them how they do it. But for me, the first thing you've got to do is start having a look at putting in this sort of series of steps. I'm not saying that it's easy, but it's not that difficult if you know exactly what you're doing. So you have got quite a lot of learning to do. It starts off small and then gets bigger and bigger and bigger and grows outwards throughout the whole of the trust. It's just making that first step. The first step, of course, is understanding what a process is, and I'm just about to come on to that.
Thank you, Tom.
I hope that wasn't a very good answer, I know, because we're talking on sort of untrodden territory.
Okay, thank you everyone for your questions and comments in the chat. I know Tom will try to get back to most of these through the special interest group, and I put the link in the chat and we'll share it again later. But back to you, Tom. Okay,
so key to the implementation of the roadmap is the adoption of standard work. And the Virginia Mason production system definition of standard work is an agreed upon repeatable sequence of work assigned to a single operator at a pace that meets customer demand. That's what they say in their production system. But let's just have a look at that in more detail. This is a Google definition of standard work, a detailed definition of the current best practice for performing a process. Using continuous improvement, the quality and efficiency of a process will improve along with the standards over time. So along with the standards over time, so those 150 standards or guidance notes that we talked about at the beginning will evolve into one over time. Virginia Mason also have got a piece on standard work here, talking about what standard work looks like in healthcare. What is standard work? And it says it's doing what the standard is. and creating and testing it. So the people that are doing the work create the standard work. And then from that standard work, they go on improving and improving and improving until it meets work as imagined. So standard work is crucial to how things you can have a look at this in your own time and see what they say in more detail. It goes on quite a bit. I don't agree with the way that they've written all of it up, but it's not so bad. Standard work has got to come from your understanding of process. So you've got to be able to break your work down into processes initially, and I'll talk about that in a minute. I don't know whether it's gone into the chat, but I will be doing another webinar in early January talking about exactly how you create standard work and how you identify your processes from what you're already doing. Because what this isn't trying to do at the moment is change anything. All it's trying to do is say, this is what we do and this is how we do it. We've been doing it for years. So we ought to know how we do it. And all it's doing is writing that down. You can learn quite a lot. The Virginia Mason Medical Center have produced 3 books now. There's 2 of them listed here. One is Transforming Healthcare, which was published in 2011. And another one is Acceleration Healthcare Transformation. Oh yeah, with lean and innovation. They link innovation to lean, and lean really it's the fourth S in the 5S. Lean and lean. It's standard work really. That's it. And what do they say here in this other one? The belief that lean thinking and innovation do not mix well is based on a superficial understanding of both. A superficial understanding. When we first raised the notion of standard work, our doctors were aghast. Standard work is the foundation for innovation. They're really good sentences, those. They mean a lot, but you've got to understand them. If you've only got a superficial understanding, then you won't ever get there. You've really got to understand it. Okay, moving on a little bit then. What sort of framework, what sort of setup do you need in your trust to establish this roadmap? Well, my view is that you start off at the top with your services. You've got your specifications and your guidance and your contracts and you get it right first time and nice. You've got organizational knowledge and you've got service quality standards. You've got all of that already. A lot of it's confusing because it's contradictory. You've got your SOPs, but SOPs aren't process-based. I think most of your documentation, in order for you to really understand the nitty-gritty of it, the granularity of it, it's got to be process-based. You've got to divide all your work up into processes. And I think you sort of need three elements to your effort. You've got to have some project management, and this isn't QI projects. It's projects that implement the roadmap. So they're the projects that I'm talking about there, not QI. You've got to have process management, and you've got to have quality management. What I made a little bit of an error here because in my view, the quality manual and the safety manual can be combined into a single manual. So where I've got quality manual there, I really mean a patient safety element to that manual as well. And all of these are sort of teams of people, and they can all be combined and linked together with IT and other groups to make sort of an engineering or a design or an improvement office. The QI team would clearly play a very important part in putting that team together. But I think the team needs to be bigger than just QI. It needs to be QI, patient safety, IT, maybe some finance, certainly in ordering and clinical pathways. All those sorts of things are combined into this group of people that operate these three pillars, and they are servicing the staff and the patients, the quality service delivery, a just culture, and patient safety. And I've said again, it's got to be a bottom-up change. So these are the important people, and processes are documented by frontline staff as work as done and not work as imagined. And eventually, through the continuous improvement that goes on, the work as done will equate to work as imagined. So this is just an idea. It's got to be put into practice by a trust to see how that actually pans out. So I've not got very much time now to do any more talking about the roadmap and the framework, and they're just ideas. I'm sure that Surrey and Sussex Healthcare Trust, who've done a lot of work with Virginia Mason, have gone part way down this path, and I'm hoping they'll come back to me and comment on what I've just said with my framework and roadmap. So, documented work as done. How do you go about it? There are lots of software packages that allow you to. I think process mapping is the best way. That's my view. In my experience over many years, is the best way to document your process is to start off with a process map. There's lots of misguidance around process maps. Really, when you start documenting a process, you do it on the back of a fag packet. You don't need any software packages to let you do it. When you do your final documentation, you might want to use a software package, but to me, it's too cumbersome. I'd rather just have it on a piece of paper. You can do it. I use Visio all the time. All my processes are done in Visio. So there's a little bit of a starting point, but that's not the most important thing to me at the moment. The most important thing is understanding process mapping, understanding process, and understanding how those individual processes fit into the rest of your work. So the basic process map to me, this is what a process map looks like. You've got a series of tasks, sequential tasks that change the inputs into the outputs. And I'm going to have a look at in a minute at a few healthcare scenarios where we can break it down into processes. And there's a spiel here about what a process is, what a procedure is, and it's talking about a degree of inspection to make sure that your output meets the standards. So each of these tasks, if they're complex, can be described in a procedure. And the trouble with standard operating procedures, they very often cover more than one process. And the elements that cover a process are split throughout the standard operating procedure. I've got some examples of that, although they're not brilliant. So to me, as I said, that's your starting point. Wrong button. That's your starting point when you're going to map a process. You get a blank sheet with a series of boxes on, and you get the frontline team to fill it in. Importantly, you've got to understand that process mapping and process modeling aren't the same. Unfortunately, most examples that we get are process modeling. So if you Google process mapping, you get all these process models. These are all process models. If you create something like this, you're never going to understand it if you're just unless you're a computer programmer that uses this sort of stuff. These process models are created for programmers and business analysts. They're not designed for frontline staff to understand. The best one that the NHS have got is for making a cup of tea. And their process map for making a cup of tea has got 17 tasks. I've redrawn that as a process map using the boxes, and there are 2 boxes. And what will people understand? 17 different tasks or just 2 boxes? So that to me is really important. You've got to get away from process modeling and start doing some process mapping. Otherwise, you'll be there all day. You'll be there all day. You don't need all of these decision boxes in a process map. They're covered in the procedure. So here's some examples that I've done. This is a ward round, and it's taken from the College of Physicians, the Royal College of Nursing, and 1 or 2 others. It's a standard that they published. Now, this is verbatim from their document for a ward round in medicine. And each of these has got some spiel that goes along with it, telling you what goes on. Some of them are quite complicated. Now, this isn't a process. This is more than a process. There are several different processes. Ward preparation would be a process. Debrief would be a process. Ward round checklist might be a process. Certainly creating the patient list and the staff schedule are separate processes. So you've got to be able to break down what you think people do into separate processes. A process really wants to contain about 5 or 6 boxes. I've got another example here for NATSIP. This is NATSIP 1. We're on NATSIP 2 now. It's quite complicated, but there are several processes here. Preparing the patient is a process. Sign in might be a separate process. Time out is quite complicated. You know, you might create that as a separate process. Certainly, handover is a separate process. And once the patient gets onto recovery, that's a separate process. So it's understanding how you break up your work into processes to make it manageable. It's no good having a process that contains 150 boxes, because that's a whole service. It's not just a process. You've got to be able to manage your processes and understand your process. The key thing about a process, it's got an input that's changed to become an output. So here you've got a patient, that's your input. You've got probably 1 or 2 other things that are like a marker pen. Then you've got a patient that's ready to go into theatre. All prepared and ready. So the input is just an ordinary patient, and the output is a patient that's ready for surgery. I hope I'm making a bit of sense with this. I've got another example here, which is an actual example that I've been working on. This is the academic SARS-CoV testing lab that was created in my university to do some rapid test sample testing for the government. So it was built out of 6 modules, and each of those modules really is a process, and each of those processes have got a process map. This isn't complete, but you'll recognize this. That will be complete soon. I'm just waiting for the staff to come along to finish it. And these are the SOPs that were created, and they're in a bit of a mess. These are unallocated, and these are to be allocated. So they can't remember what they were written for. But anyway, these are examples of typical SOPs where there's lots of standards saying, oh, we've done this and we're going to review it, and then they get down to the nitty-gritty of it here, the actual procedure. So, you know, your process documentation needs to be fairly simple, because you don't really want to be repeating too much that the medics have done all of their training to enable them to undertake. But you want to sort of guide them through a standard process rather than a standard interaction with the patient. That's why it's very, very it's going to take some skill to work out how to write these procedures for individual processes. The procedures will come from the existing SOPs in many cases, but you can be sure that most of the the procedures within the SOPs have got workarounds. So what are you going to write down on your work as done, your workaround or your actual documentation in the SOP? Well, it's got to be the workaround that you record. Okay. Moving on a little bit. I've already shown you the Toyota Kata. That's really important to me. This CI, the difference between CI and QI is important. As we already heard, QI is very cumbersome. CI can be just a group of people in a huddle. Having said that, you've got to be fairly careful that you get your changes approved by whoever's senior, and also that the documentation is updated. And finally, I've got something else here from Virginia Mason Institute that regarding their work with the NHS, and it tells them a little bit about how long they've been working with the NHS since 2000 for 14 years. For 14 years. Anyway, they're talking about improvement and quality management systems and NHS improvement and the core ingredients and the impact report, but throughout all of this, they don't mention standard work at all in any of these threads. There's the foreword. I'm not too sure about foreword. This is from the hospital in Worcester where I live. I don't know how it got into this report, but anyway, right the way through, they go through all of it, and they've got a bit from the Warwick Business School, Helen Bevan, Nicola Burgess. You might know her from Kew. They go all the way through, and then right near the end, they've got standard work, but they've got no text throughout the whole of this on standard work, and that's the key activity that has made Virginia Mason what it is standard work. They go right on and talk about building capacity, and here they've got their the Virginia Mason production system, the principles of it. Value streams are really what are not too different from standard work. They're more of a patient journey or a clinical pathway, but it's made up of standard work. So there's something else that you can read and compare this with what I've been saying. All of this core values and all sorts of things, they evolve from standard work. You can't put these on top of work as done. You've got to work from the bottom upwards, in my view, and then you start to address some of these issues in more detail. Once you've conquered the problem of standard of work as done equals work as imagined. So getting back from where I started, I think we're nearly out of time.
Yeah, Tom, I know there's a lot to share still, but I just want to acknowledge that we are at time and need to wrap up. And just want to say it's okay to leave if you have to, if you see other people have meetings to go to. And I know Tom will be following up in the special interest group. I shared the link in the chat. We'll also send out an email with the recording and probably also the chat, because there's lots of great sharings in there, and any news on an event in January. So maybe some final words, Tom, and then we'll wrap up.
Yeah. Well, thank you very much, everybody, for joining me. And I just wanted to end on this these two formula. I think they're absolutely crucial. And then finally, thank you. And there's the link if you want to have a look at the slides, but I'm sure it can be put in the chat. And my email is here. If you want to email me with any questions, I will get a copy of the chat and answer all of the questions in writing, which will be either sent to you or published on the Q Community platform. Thank you very much.
Thank you, everyone.